Hi. Thank you. It's a pleasure to be here. And if anybody can't hear me, just let me know. On this fine, cold morning, the campus is gorgeous with the leaves turning. It really is a beautiful day, just a little chilly. Okay. So the 90-year-old walks into his doctor's office and he says, "You know, Doc, my right knee is killing me." And she says, "So what do you expect? You're 90 years old." And he says, "Well, you better tell that to my left knee because it's not the one that's hurting." What is normal aging? What is a normal aging change, and what is a symptom of disease? That's what I'll be talking about this morning. And we'll be starting with somatic and sensory changes, and then I'll be talking more about cognition and just ending up on a thought about medical care of the aged. Cells age, bodies age because cells age. And just the way that we get gray-haired, you can just imagine that all of our cells are becoming senescent also and having gray hair and slowing down a bit and dying. And this happens in all of the organs of the body. It happens in the brain and the skin and the GI system and every place else. What eventually happens is that at a certain point, there's a lot of redundancy, but at a certain point, the cells, enough of them become weakened or die so that eventually organ system function does change. But there's a lot of reserve built into the system. So even though the function of the organ is declining, it's not until there's a great deal of decline that we actually experience a functional change. And that's what cellular aging is about. Organs are able to adapt and compensate for a very, very long time. It becomes, for example, under stress that they are no longer able to compensate. And that's a theme that you'll hear a lot from me in terms of normal aging, that loss of reserve. It's only after a great deal of dysfunction that the organs actually malfunction. Well, is joint pain a normal part of aging? And as I alluded to, no, it's not. What is a normal part of aging is joint stiffness. Okay? And as some of us have gotten older, we realize that it just ain't so easy to get out of bed in the morning, and that good hot shower on the back and on the joints is really important to help loosen that stiffness. Arthritis is a very, very common disease in older people, but it is a disease state, and that's what's associated with pain. The reason that joints become stiffer is because there are changes in the water and chemical composition at the joint endings. There's also a decline in the blood circulation, so that our joints every moment are being are accustomed to dealing with these little micro injuries. And as the blood flow declines, the joints become less able to heal those micro injuries. And that also becomes tied to the susceptibility to arthritic and other painful condition changes. There are also changes in our skin. And what's interesting is that the yellowness and the roughness and the wrinkling that we usually associate with aging is not normal aging, but more likely to be caused by photoaging. The changes that occur in our skin from normal aging is mainly a thinning and a drying. Okay? There's a loss of the subcutaneous tissue, in other words, the skin underneath, the tissue underneath the skin. And you'll see sometimes older people, and their skin is practically translucent because it has become so fine and thin and drier. That's a normal aging change, not the wrinkles and the freckling and the roughening that we see because too many of us have become used to playing in the sun. There's also a normal decline in height. Okay. I'd like to think that I'm getting taller as my mother is shrinking, but that's really not the case. The average loss of height for an adult is between 2 and 3 inches. Some people it might be more, some people it might be less. And this is due to thinning of the padding between the bones of the spine, the discs of the vertebrae, as well as postural changes. There's also a normal decline in bone mass. And this starts from the age of 20, and it's all downhill from there. Okay? Peak bone mass is at age 20, and that's why there's a whole lot of emphasis on making sure you have your calcium and for your teeth and your bones and all. When bone mass loss reaches a certain point, it's then called osteoporosis, which is a disease state, and it's just a certain place where there's enough loss that there is an association with increased fractures. That intermediate stage where there is a loss of bone and the bones are thin but they haven't quite reached that disease state is called osteopenia. And this is a normal loss of bone mass that occurs. If it gets to a certain point, we call it a problem. Why is osteoporosis more common in women than men? For two reasons. One is that with the changes in hormones for women at menopause, the change of life, there is a more rapid decline of bone mass. But the other reason is that women start out with a lower bone mass to begin with, so that it takes less loss before they reach that state where they are more prone to experiencing fractures. Okay. There's also changes in gait. And when I think of a normal geriatric gait, I always think of George Burns. And if you can still picture the way he used to walk, it was stooped, and his arms were kind of tight to his body. Here comes my George Burns imitation. And he was kind of stooped, and his arms didn't have a lot of swing, and his knees were kind of bent, and he had a wide base gait, and it was slow, and there wasn't a lot of lift. He didn't lift his feet very high. And that, almost a shuffling, in an exaggerated way, is a normal geriatric gait due to postural changes and other changes. Balance systems as well. In addition to the changes in posture and gait, there's also changes in body composition, changes in the relative percent of water, fat, and muscle. And we all probably have a pretty good idea which direction that goes in. There's actually a change, a loss of muscle between 30 and 40% in men from the ages of 20 to 80. That's 30 to 40% loss of muscle mass. This just happens. Of course, there's a great deal of attention right now to preserving that loss or rebuilding the loss of muscle in older ages. But the loss that occurs is not because of inactivity. There is that normal loss that occurs and the changing of percentages of water, fat, and muscle. There becomes a lesser proportion of water in the body and a greater proportion of fat. And this has implications not only for appearance and vanity, but also, for example, the way that drugs are metabolized and cleared from the body. In all of the various organs, there are also changes. Okay. And these are due to the cellular changes that I alluded to before, and they are essentially normal. It takes quite a bit of cell loss before these changes become manifest in the functioning of the organs. And whether they cause any human functional changes depends on the organ and the amount of stress. If any of you have taken an aerobics class, they teach you how to take your heart rate, your pulse, and you take it for 10 seconds, and then you multiply it by 6. Okay. Or you take it for 6 seconds and multiply it by 10, depending on the instructor. And your goal is to reach 80% of your maximal heart rate and to exercise at that level. Well, the way that you'd calculate that level that you'd like to get is maximal heart rate is approximately 200 minus your age. Well, okay. So if I'm 20 years old, if I'm 20 years old, I'd want to be exercising close to 180 beats per minute. That's pretty quick. If I'm 80 years old, 80 from 200, that's 120. That would be the maximal heart rate that I'd be exercising toward. That's a huge difference between 120 beats per minute and 180 beats per minute, when normal heart rate is supposed to be between 60 and 100. Okay? So that means between normal 60 and 100, the 80-year-old is only going to get another 20 beats to be exercising maximally. Okay? Everyday use, that really has no bearing on anything, but it is a normal aging change that we see. Along with that, older people take a longer time to recover from exercise, and they do this with all sorts of fancy tests of grip strength and how long it takes for the muscles to be able to fire again after a certain amount of exertion. Blood pressure also increases normally with age. Not a lot, just a few points, but when blood pressure reaches a certain level, it's considered too high and it's called hypertension. So there is a greater incidence of hypertension in older people, in part because of the normal aging change. And that's because the blood vessels get stiffer. And if the pipe gets stiffer, the pressure is going to be higher in that tube. In terms of lung function, there's also a normal decline in age. If we smoke, that decline gets even greater. But there is a normal decline of a couple of centimeters of pressure per decade as we get older, and this just occurs normally. And for the most part, this doesn't influence us at all. It does, however, affect how we can experience stress of exercise, and also contributes to the lesser ability of older people to fight off pulmonary infections, to become more oxygen dependent sooner if they are having a pulmonary infection. In other words, to be able to have less resilience to stresses that younger people wouldn't have so much trouble with. Similarly, kidney reserve declines. There's a loss of kidney function, 25 to 30% in men from the ages of about 30 or 40 to 80. Okay. We measure renal function in creatinine clearance, and normal creatinine clearance for an 18-year-old man would be about 125. Now, creatinine clearance is based on age and muscle mass, and which we use weight as a surrogate estimate of. And also and how the body is actually clearing the creatinine. Normal creatinine clearance in a 80-year-old may be 30. That's a huge decline from 125. And for the most part, we're not saying that that 80-year-old is having renal failure, but he has had a loss of renal ability. When we talk about loss of function, we're talking about a creatinine clearance of about 10 to 12. So that 80-year-old is a heck of a lot closer to it, but that doesn't mean that he's going into renal failure unless, of course, there's a great deal of stress put on his system. And then, of course, there's less reserve, and it would take less to push him over the edge and have his kidneys fail. For example, stresses of volume depletion, in other words, dehydration, if the kidneys don't have enough blood circulating through them, and conditions of, for example, having to metabolize too many medications through the kidneys. So that might contribute to too much stress and a loss of function. That 18-year-old can experience quite a bit of stress on his kidneys before it affects anything. The 80-year-old, it's going to show its effects a lot sooner. Loss of kidney function also contributes to the, there's two functions that kidneys have. One is to clear waste, and the other is to conserve fluid. You know that when you get up in the morning and you have your first urination, it's a lot more concentrated. It's a lot yellower, thicker, smellier than it is later in the day after you've been up and drinking. Or if you've exercised a lot and haven't drunk enough, you'd find that your urine is concentrated. What this is your kidneys are pulling in fluid into your body because you need it and excreting less of the water. Okay, that's how we conserve fluid in our bodies, by concentrating the urine. As we get older, we have less of an ability to concentrate the urine. We can still concentrate it, but it's not able to get quite as thick and yellow as we are when we're younger. And that has implications for a greater susceptibility to dehydration. So that becomes a very dangerous slope to be sliding down if you are able to concentrate your urine less, make your kidneys more susceptible to becoming dehydrated, and then, of course, them needing to have that function to be able to maintain function. And there are decreased responses to temperature extremes. And this has to do with, in fact, how do we get rid of excess heat? Is we sweat it off. We have our sweat glands. As we get older, good news and bad news is we have fewer sweat glands. Okay? Older people perspire less. Okay? What that means is they use less deodorant, but it means that they're able to cool themselves off less efficiently in cases of extreme heat. In cases of extreme cold, related to example, that thinning of the subcutaneous tissue, there's less insulation. So older people are less able to adapt to very cold conditions. Under normal circumstances, that's fine. But why in these big cities, when the temperature is reaching 102 and people are living in tenements without fans, is there a greater loss of people who are in their 70s and 80s as opposed to their 20s and 30s? It's because as we get older, there is a lesser ability to respond to temperature extremes. Okay. Now, the important point about all these changes that I've mentioned so far is that they're normal aging changes. These are not diseases. I haven't spoken about one disease state yet. When we're talking about diseases in older people, the most common are, number 1, heart disease, 2, cancer, number 3, strokes. Those are the number 1, 2, and 3 killers. Number 4, by the way, is pulmonary, and number 5, anybody know the 5th leading cause of death in older people? It's Alzheimer's disease. And we'll get to that when we talk about cognitive changes a little bit later. But these are the most common medical conditions that do affect older people. Heart disease with loss of viable muscle due to infarctions, in other words, a stoppage of blood flow. Same pathology as in strokes. You could think of a mini stroke or a TIA, a transient ischemic attack, as sort of like angina of the brain. Okay. In other words, there's a part that's not getting enough oxygen, enough blood flow, so that there is a temporary loss of function. Okay. In older people, heart disease, number 1 when we think of a heart attack in a younger person, we think of the crushing chest pain, the shortness of breath, the paleness, the gray complexion, and clamminess and nausea. That's what we would think of. In an older person, the most common symptom might be absolutely nothing. It might be shortness of breath, just sort of generalized weakness and malaise. It might be a change in mental status. And we'll get to that a little later, is that diseases often present differently in older people. Number 5 on this list is osteoarthritis, and I mentioned that that is extremely common in older people. And between hypertension and osteoarthritis, those are the 2 biggest causes or presenting symptoms for doctor's visits in older people. Neurologic diseases such as Parkinson's disease or strokes could be considered a neurologic disease. Those are common in older people, certainly much more so than in younger people. All sorts of mobility disorders and falls. Okay. In terms of falls, what is the population most likely to fall? Is it older people? It's actually children. When you think about what population, what group of the population is most likely to fall. The problem is that older people, when they fall, are more likely to hurt themselves, to become injured. As I say, I don't care if my patients fall. It's not the fall that bothers me, it's the landing that's a killer. Okay? And older people are much more likely to become injured if they fall. Diabetes, with the increase in obesity, we're certainly hearing an awful lot more about the incidence of diabetes. But also, as we get older, there are changes in insulin resistance that leads to a susceptibility toward diabetes, which is in fact a disease state. Okay. And finally, peripheral vascular disease. We are hearing more. There's a bunch of play now about peripheral PAD, peripheral arterial disease. Okay. And we're hearing about, if you're walking and get cramps in the back of your legs, if your circulation isn't good, this is a risk, and they tell you what medications you should be on, which isn't necessarily the case. But anyhow, we're hearing a lot more about peripheral vascular disease. There are two kinds. There's the arterial, which is when there isn't enough blood flow getting to the periphery, the extremes, the feet usually. And then there's also venous arterial disease, venous stasis. And if you think of the cold, white, pulseless extremity, you'd be thinking of peripheral arterial disease. In other words, not enough blood is getting in. But if you've seen older people who've had very reddened, warm, swollen extremities, that could be a symptom of venous disease, venous stasis. In other words, the blood is getting down to the feet, but the venous system is not working well. In other words, the blood isn't getting returned to the heart as well, and it's pooling. And that is more common with aging as well, because the veins have valves that help pump the blood to get back up to the body, back up to the heart, so that it can be recirculated. And those veins can become less strong or incompetent. So that can contribute to the venous arterial vascular disease. Sensory changes. It's commonly thought that older people lose their taste for food. They lose their ability to taste foods. And actually, there's not that much of a change in taste buds. What there is a huge change in, though, is the sense of smell. And this declines quite vividly in older people. And that sense of smell is very closely related to our sense of taste. Older people are often less able to distinguish the different flavors in a dish that has a lot of different flavors in it. Or that older people may say that they have experienced a change in their taste, that all of a sudden they don't, they really crave things that are sweeter or saltier or less salty. And those are oftentimes a change in the sense of smell, contributing to the change of taste. Okay. There's a loss of high-frequency hearing. And this is inevitable in older people starting from about the age of 30 on. And when it affects one's ability to function is usually when there's a loss of the ability to interpret speech. Now, interpretation of speech is largely dependent on the ability to understand consonants like C and D and F and S. And it's those consonants that are, and I don't quite understand enough about speech pathology, but those are the consonants are in the high frequency ranges of hearing. So it's when those become affected enough, it really affects people's ability to understand speech. And you end up with these jokes like, the two guys out on the golf course and one saying, what day is it? It's Wednesday. No, it's Thursday. Yeah, I'm thirsty too. Let's go for a beer. That was supposed to be funny. But the difficulty of interpreting speech is related when it progresses to enough of an extreme to a loss of ability to interpret speech. And then we think about people as having hearing loss. Hearing loss seems to be more common in men than women, and it's not clear if this is because of noise exposure or not. And we'll probably know about that in a few decades when we see that women who've been historically not as accustomed to dealing as much with noise do nowadays. And so we'll see if that is in fact the case. Okay. There are changes I'd like to say it's not a difference in our near vision, it's more that our arms become shorter, that we have to hold things out a little farther to read because we lose that ability to focus our eyes on things closer to us. In other words, we become more farsighted. We can see things farther, but we have to kind of push them away because we can't. If you think about crossing your eyes and you think about, the muscles that it would take is to cross them, and if you could cross them less, it means that you'd have to put stuff out here to have them where you could see them clearly. This is a normal change. It starts at about the age of 30. It's all downhill from there. It usually becomes such that people have to start wearing reading glasses in their 40s. Okay. As we get older, it takes longer to adapt to light changes. And this is actually a very, very sensitive indicator of age in research studies. Now, I can go with my daughter into a movie theater, and you step in, and all of a sudden it's really dark because I'm never on time for anything. So I'm walking in, the movie has started, it's dark, and my daughter's saying, "Come on, Mommy," and it's like, wait a second, I've got to get my eyes to, before I've got to be able to see something. And it's remarkable how quickly she's able to see in a very darkened room. Or, conversely, if you're going out to the very bright sunlight, sometimes it takes a moment to be able to get your eyes together so that you can actually, so that the pupils contract, so that there's not so much light come in. It happens instantaneously for her compared to me. What a difference 40 years can make. There's also an increased sensitivity to glare, and this contributes to the difficulty that older people often have with night driving because of the glare of the lights and the wet streets and the mainly the lights. And there's a decline in contrast sensitivity. In other words, being able to distinguish background from ground. And oftentimes, when you walk into a nursing home, you'll oftentimes see that there is a difference in color between the floor and the walls, or that they will have a color difference in the middle of the wall, because you really hate it when people start walking into walls, The idea of having, carpeting that doesn't have these great big designs that become confused with the furniture, that you'll oftentimes see if you walk into facilities. And there's, of course, all sorts of research on this, but there is a decrease in ability to distinguish background from object. Now this again, those are normal changes. Common diseases of the eye are, I list 3, cataracts, which are due to a thickening of the lenses, a clouding of the lens, and it in fact leads to clouded vision. What's nice is that cataracts are very easily cleaned out or extracted nowadays, and the results are very dramatic in terms of improving vision and improving the ability to deal with glare. Number 1 cause of blindness in Caucasians is macular degeneration. Number 1 in African Americans is glaucoma. And there's a difference in the pattern. There's a difference, of course, in the pathology of what's happening, but there's a difference in the pattern of visual loss that you see. In macular degeneration, the macula is the part of your retina, the visual cells. It's the point of maximal sensitivity. It's that point right ahead of you. If that part is degenerating, there's going to be a hole in your vision. But there is a maintenance of the peripheral vision. So somebody with macular degeneration won't be able to necessarily see your face, but they'll be able to see where they are. And they are relying on the outside of their vision, not necessarily the central vision. Glaucoma, the changes are due to pressure changes in the eye, and what you lose first is the peripheral vision. So this has important implications, for example, for driving, or for being able to see things outside of just the front. It would be harder to make a left turn. It would be harder to stay in a lane if your vision were cut off at the sides. Okay. Glaucoma is much more treatable by medications to reduce the pressures. Macular degeneration, there's 2 kinds, wet and dry, and they're not, one of them, the less common, is partially treatable, the other is not. Okay. Changing over to cognitive changes. There are normal changes in how our intellect works as we get older. And of course, people are always worried about Alzheimer's disease. But let me distinguish. To explain how the normal changes with age are in the brain, I like to think of the brain as a great big filing cabinet. And if you open up the drawer of a 16-year-old's filing cabinet, it can be virtually empty. Some emptier than others. If you open the drawer of an 80-year-old filing cabinet, it is absolutely jam-packed with folders of memories and experiences and lessons learned. So you could think of it as if the 80-year-old is trying to remember, let's see, my niece just had a baby, I have to remember the baby's name. I've got all these folders to sort through to find the right folder to put that name in. And it's going to take a little bit longer to retrieve that name out of that correct folder, assuming that it was learned and put in the right folder to begin with. So that has a twofold difference. One is that it takes longer to learn new things as we get older. It's not that you can't teach an old dog new tricks. You can. It just takes a bit longer. And that retrieval piece is trying to remember that name once it was put in that folder. And that's that tip of the tongue phenomena, or that, the senior moment is you just can't think of it. And you'll think of it tomorrow or the next day. But at that moment when you want it, you've got too many folders to sort through to be able to pick it up immediately. That's a normal aging change. When you remember what you're trying to, when you remember what you forgot, when you remember that you forgot something, that's probably a normal aging change, in contrast to completely forgetting that you forgot. Okay. Another way to think about it is that there are different kinds of cognition, and some of them are more affected by age than others. What is mostly affected by age are things like episodic memory. What did you have for dinner last night? Okay. That sort of forgetfulness is much more common in older people. When you put older people in a lab compared to younger people, and you do timed memory tests or timed tests of attention and concentration, you'll find that older people will tend to score less well on those tests. Recall, that filing cabinet thing, being able to pull something up and recall it, tends to be less good in older people. And finally, the processing of new information can be slower in older people. And the changes that this seems to represent are kind of like a loss of working memory, or a smaller working memory. It's a little tougher to keep too many facts in mind at the same time. A normal change. Okay? When I'm talking to my mom sometimes, and she's a perfectly normal, cognitively normal 78-year-old. And I find that she can be, if I'm talking about too many things at the same time, it's like, Michelle, slow down, slow down. And it always strikes me because I'm not used to my mom doing that. But I've noticed that as she's gotten older, too many things at the same time being thrown at her, it's just harder to keep track. And this doesn't mean that she's becoming senile. It's just a smaller working memory. Now, what is not affected by age are things like language and vocabulary, which in fact, if anything, is shown in studies to increase as we get older. Visual spatial ability is that ability to not get lost in a place where you shouldn't get lost. Visual spatial ability. Years ago, my husband and I had to go someplace. We were living outside of Philadelphia. And this was in the days before Google and all that stuff. And gosh, you wanted to get someplace, you had to take out a paper map and look. So we took out this map, and we're trying to figure out how to get to this place in the suburbs. And we, figured it out and got in the car and went. And over a year later, we had to go back to that same place for another function. And I said, Marty, do you want me to pull out the map? He said, no, I remember how to get there. And sure enough, we get in the car, and all of these twists and turns and these, these suburban subdivisions, he got there without a problem. And I was just amazed. That's an example of a good visual spatial ability. Now, for someone like me, I don't have it to begin with, so nobody will ever notice if I lose it. Bad news is I won't get better. But my husband will still be able to do that, God willing. Okay. Recall of events in one's personal past is not something that people normally forget. People normally remember, who their first grade teacher was and where they grew up and, what their first job was and the name of their first boss and stuff like that. An abstract reason in problem solving does not normally decline with age. That's different than processing. The actual ability to reason and problem solve is not something that declines with age. When we begin to have problems, we see that these functions that don't tend to be affected by age do become affected. And that's when we begin to be concerned about things like Alzheimer's disease and other dementias. Alzheimer's disease, we just mention it and people get freaked out. It's very, very frightening to think that you are losing your mind. The prevalence today, it's estimated that over 5 million Americans over the age of 65 are suffering from Alzheimer's disease, and this number is expected to triple by the year 2040, by 2050, when the baby boomers have reached their peak. Now, what is it that the incidence is increasing so much? One is that Alzheimer's does increase with age. Approximately 5%, that's my phone, I'm sorry, ignore it. Maybe 5% of people under the age of 75 have Alzheimer's disease. Over the age of 85, about 40% of people have Alzheimer's disease. So the numbers do increase dramatically with aging. So that's one reason we're seeing such an increase in prevalence. The other reason is that people are living longer. Okay? And as the demographics are changing now, that we're having this big merge of people who, a huge cohort is entering this age, we're going to see a huge increase. In North Carolina alone, they're estimating a 31% increase from year 2000 to 2 years from now. Annual cost to the country is over $100 billion a year, and as I mentioned before, it's the number 5 cause of death in people over the age of 65. Mild cognitive impairment is not dementia. It's an intermediate stage that we think either could be a prelude or it could be a state unto itself, and it's defined as objective and subjective cognitive impairment that doesn't affect one's ability to function in daily life. Alzheimer's disease is a type of dementia that affects memory and other cognitive functions to the degree that they interfere with normal social and occupational functioning. Okay. Mild cognitive impairment is a objective and subjective finding of changes in cognition, but they don't interfere with normal cognitive functioning, with normal daily functioning. So it's unclear, and this a huge amount of research is going on, is this a early Alzheimer's disease or is it something that is independent? And the research is showing that, like so many other things in medicine, over time, a third of these people get better, a third get worse, and a third stay the same. So we don't know yet about mild cognitive impairment. We'll be hearing an awful lot more about it. 3 Ds are depression, delirium, and dementia. Alzheimer's disease is the most common dementia. Sometimes we use the terms interchangeably, but Alzheimer's disease is in fact the most common type of dementia. Okay? It's not an either or. What's different about the elderly? We've talked about the physiologic and the cognitive changes. And when it comes to health care, we're often talking about not only individual differences in health status. In other words, you can think of some 80-year-olds and you can think of other 80-year-olds, is that there's often multiple interacting conditions going on. If somebody is falling, it's not because they have X or Y. It's because they have some arthritis, they had a stroke, there might be a little bit of Parkinson's disease, it might be some environmental factors or problems with their environment. And things don't always present atypically. I mentioned for a heart attack, for example. A urinary infection in an older person may present as simply a change in mental status, that they're acting more confused. And because of the physiologic changes and the use of different treatments at the same time, older people are oftentimes more susceptible to adverse effects of individual medicines and then, of course, the interactions of them, which suggests that in health care of the older people, it's a fine balance between too much and too little. Oftentimes, the goal is not to increase long life, to increase the lifespan, but it's to improve the quality of life and functioning. Okay? Somebody may not want to be cured of cancer when they're 85. They just want to keep spending time with their family and be able to get to the bathroom themselves and feed themselves. That's a whole lot different than living for another 20 years or 30 years as the 25-year-old with, God forbid, the similar cancer might have as their goals. It's common to overtreat, and it's also common to undertreat. Okay. We don't want to undertreat by just attributing symptoms to old age. That 90-year-old on the first slide, his left knee was not bothering him, but his right knee was, and that should be treated. And we can't be so afraid to treat it that we leave him in pain. Yes, he has a greater susceptibility of side effects to medications, but that's not an excuse not to treat. At the same time, we don't want to overtreat and give somebody chemotherapy for stuff that isn't going to necessarily be affecting them. In conclusion, aging causes changes in all organ systems, which can be distinguished from disease, need to be distinguished from disease. Disease management needs to distinguish between disease and normality. And in medical care, health care of older people, the primary goal needs to be do no harm. Thank you.